When insurance contract examiner Debra Violette was diagnosed with stage 3 lung cancer in 1998, her prognosis was grim. 10% chance of survival in 2 years. Deb started treatment with 3 rounds of chemotherapy, spaced 21 days apart, followed by surgery to remove her right lower lobe, and ending with 25 rounds of radiation. She changed her lifestyle by increasing daily activity, incorporating vitamins, macrobiotic diet, and magnet therapy. Diet-wise, she tries to avoid gluten, potatoes, tomatoes, peppers, and eggplant. No red meat or dairy. She limits sugar of all kinds. She does eat sugar occasionally, but doesn't make it a daily practice. Usually the sugar comes from fruits and berries, but occasional and rarely refined. Her diet is basically vegetables, fish, and some chicken. Has she ever cheated? Yes, but from time to time only. Her biggest downfall is fried and salty foods. She did fear death, however, that did not last long. Deb attributes her survival to traditional treatments, alternative treatments, and giving hope to others in her shoes. 10% chance of surviving 2 years, thriving 14 years later. The Thrive Channel congratulates Debra Violette, ultimate survivor. I am a breast cancer survivor, a blood cancer survivor.
I'm Dr. Holly Lucille, a naturopathic doctor.
I am a mom of a teenager, a basset hound owner, military wife.
My name is Dr. Deanna Atai, and I'm a breast surgeon.
I am a cancer survivor who is looking for answers just like you.
I'm Debra Violette. I'm a medical oncologist.
What works, what doesn't? Welcome to Thrive with Namrata. Can surgery or biopsy of a tumor actually spread that tumor?
There is no question that surgery and a lot of other treatments, as well as just the stress of treatment, can have suppressive effects on the immune system. But I think where some of this comes from is people will say, my great-grandmother or my uncle or some relative had surgery, and the next thing you know, they had cancer all over their body. Realize that 20, 40, 50 years ago, we didn't have the kind of diagnostic tests that we have now. So if someone came in with a lump in her breast, the only thing we had to offer her was surgery. We didn't know if it had already spread to the bones or liver or the brain. And it is very possible that with the immune suppressive effects of surgery, the stress of the surgery, that may have caused the metastatic disease that was already present to come to light. That's probably not what's going on nowadays. No question, again, there's some immune suppressive effects. There's been studies looking at the suppressive effects of blood transfusions. But we generally don't take patients to the operating room nowadays, at least for breast cancer, when we know that the cancer has spread other places. We would generally start with other treatments first. So in general, surgery for many cancers remains the primary way to treat. We still have to have a way to get that main tumor out of the body.
It's important to realize that even though a biopsy or surgery may temporarily increase the amount of cells that are going out in the circulation, that even a tumor that's left alone is constantly shedding tumor cells as well. And that's why cancer cells spread. So you do want to get that primary tumor out. That's pretty much the standard approach for any curable early stage cancer. Is you start with that as your main approach, and then your other treatments are much more effective when you're only having to deal with microscopic cells that may be elsewhere.
That's a great point.
The only other point I'll make is as far as needle biopsies. You know, it used to be, again, that if you had a lump in your breast, the first place you went was to the operating room. The only option we had was a mastectomy or breast removal. The standard of care now is to do a needle biopsy first, because I want to know for sure not only that it's cancer, but what type. I might want to have the woman get an MRI, maybe genetic testing, maybe she needs chemotherapy or other treatments first. So those needle biopsies are really critical to being able to plan a woman's surgery so that when we do go to the operating room, we're hopefully just going once and she's getting the right operation.
And I think this is the kind of information that people need, and I'm hoping that they're getting it each and every time something comes up that's suspicious, because there are those thoughts out there. I have plenty of patients that are conflicted about even getting simple information, more diagnostic material available so that we can just understand what's going on. And I think that when doctors take the time to, first of all, validate their fear, okay, that perhaps a biopsy, fine needle biopsy, a lumpectomy is going to, have more risks than benefits. Validate their fear, but then go through the information clearly. Not just stick to, okay, this is standard of care and this is what we're going to do, but so we can really allow them to make their informed decision.
So this one, Deanna, I have to ask you though, there's a thing, and I don't know how to pronounce it, morcellation, a type of hysterectomy, a type of surgery, now proven to possibly spread cancer in women?
So morcellation is a little bit different. What morcellation involves is actually going in through a small incision and breaking up the tumor into little pieces and then taking it out. And I know it's been used for a while. It's used in a lot of benign uterine conditions like fibroids. But the problem is if you do have a tumor there, that could potentially cause it to spread. In general, for cancers, and this goes back to the days of Halsted, the no-touch technique, you want to take that cancer out with some degree of a margin. You don't want to be cutting into the cancer when you're in the operating room. So as far as the morcellation for benign tumors of the uterus, that may be fine. But it becomes a question, do you really know for sure that it's a fibroid versus a uterine cancer when you're going in to do the treatment?
But I guess the question though is, if you're cutting into a tumor, if the uterine fibroids are actually malignant and you're cutting into the tumor and you're spreading it, then just for a layman, the conclusion would be, then why, when you're cutting into any tumor, why wouldn't that spread it?
Well, uterine fibroids are generally benign. So uterine fibroids generally do not have the potential to spread to other parts of the body. But again, the problem can be, it can be hard before the procedure to determine whether it's a benign or a malignant tumor of the uterus. So in my opinion, if there's any doubt, you shouldn't be doing the morcellation procedure.
But surgery in general is actually recommended.
Absolutely.
Yes, and keep in mind that most surgical procedures are aimed at removing the tumor without transecting or cutting through the tumor. Right. That doesn't always happen, of course, but even if there may be that occurrence and some cells get out, we believe it's still better to get the primary tumor out, because if you leave it in there, it'll continue to seed. There's no stopping that.
Debra Violette, thank you for being an ultimate survivor and ultimate thriver. We'll see you next week.